All right, hi everyone. Thank you for coming to tonight's Grand Rounds with Dr. Ige. If anyone has any questions throughout the talk, please just write them in the Q&A box at the bottom of your screens, and then we'll get to them at the end. Now I'd just like to introduce our speaker. Dr. Simbo Ige serves as the Assistant Commissioner at the Center for Health Equity and Community Wellness, guiding the division's efforts to eliminate health inequities resulting in premature mortality. Dr. Ige leads the Center for Health Equity and Community Wellness's work on social determinants of health and programs addressing both upstream and downstream interventions to improve health and well-being of New Yorkers. She has over 16 years experience leading and evaluating health equity initiatives in over 40 countries. Dr. Ige is a public health doctor with graduate degrees in epidemiology, biostatistics, and public health. And without further ado, take it away, Dr. Ige.
Well, thank you, everyone, and good evening to you all. Today, I'm going to attempt to help the colleagues in the room think like a public health doctor. So I want us to reflect on the public health perspective of vaccine preventable diseases, and then to close by helping our providers understand how to build vaccine confidence using some of the learnings that we have accumulated over the COVID pandemic. So how does public health physicians or practitioners or professionals think? There is a public health approach. It's very similar to how we think in medicine. The public health approach is a 4-step process that is rooted in science, and it can be applied to any health problems that impact populations. The main difference between medicine and public health is the population we serve. In medicine, our focus is on the individual in front of us, and in public health, the focus is on the larger population. So in public health, we start by defining and monitoring the problem. We identify the risk and protective factors, and then we start to develop and test prevention strategies, and then we assure widespread adoption. So another area of difference between public health and medicine is medicine focuses a lot on treatment. We focus a lot on prevention. So a little about vaccine preventable diseases. There's been a lot of excitement around vaccines in the last few years. Why are we so interested in vaccines? Because vaccines have helped us all but eradicate diseases. There are many diseases that are prevalent in other countries that are not here in the United States because of vaccine coverage. So example is, if we look at measles, throughout the 20th century and look at morbidity from measles, we had almost over 500,000 cases of measles in the 20th century. In 2020, we had 13 cases of measles in the entire world. In the US, 13 cases of measles, down by 99%. Vaccines, pertussis, mumps, rubella, smallpox, eradicated, 0 case anywhere in the world. Diphtheria, polio. We had in the 20th century 16,000 cases of polio. In 2020, we had 0 cases of polio. So we are huge proponents of vaccines because it just helps us remove diseases that are preventable from the public health portfolio of work. So the challenge, though, I started by saying you define the problem. Now we have a problem. There are at least 2 to 3 million deaths every year from vaccine preventable diseases, from diphtheria, tetanus, whooping cough, etc., around the world. These are diseases that could have been prevented. Now, when vaccine coverage is high enough, it can also stop the transmission of infection completely. We are worried because vaccines are widely available and free, and yet we still record over 1.5 million deaths each year from vaccine preventable diseases. Now, we haven't even added COVID to the equation. This is just other routine vaccine preventable diseases. 1.5 million people that could have been prevented if they had received the vaccine. So COVID emerged 2019, 2020, everyone is scared out of their wits. No one is going anywhere, no one is doing anything. And the impact of the pandemic is not just on the lives lost directly from COVID. An estimated 23 million children worldwide missed their routine vaccination in 2020, placing millions of children at risk of life-threatening vaccine-preventable diseases. So COVID-19 has also increased the risk of outbreaks in the United States because many countries put off their vaccine campaigns. Routine vaccination rates in the United States have dropped, so their threats outside, their threats inside. And in New York City, declining vaccination is of concern due to recent outbreaks of vaccine-preventable diseases. So we know we're not immune. We have seen this happen before several times. When vaccine rates drop, we get an outbreak. Maintaining high population immunity through high vaccination rates is critically important to prevent future outbreaks. Now, this is the trajectory of routine pediatric vaccinations administered to children 0 to 18 years in New York City. There are three different lines here. The orange line, which is in 2021, the gray line, which is in 2020. And you will see that in 2020, we had higher rates, dropped in 2021. In 2020, we had higher rates at the beginning, and then the pandemic struck, and then things nosedived. I mean, it was a sharp drop in 2020. You will see how, the vaccine coverage just dropped so drastically, and then things started to pick up a little. Now, we have still not fully recovered in 2021. Rates are still low. And before the pandemic, we were doing much better in terms of vaccination coverage. So we're concerned that the lower vaccination coverage puts our city at risk of potential outbreaks. Now, there are differences in vaccine coverage by race and ethnicity. In New York City, lowest vaccination coverage is among white, non-Hispanic residents. Vaccination coverage in 2019 was 58% among white residents. In 2020, it dropped to 57%. In 2021, it was less than 50%. Relative to other populations, we are concerned about the low vaccination coverage for routine immunization, and that's the 4313314 series that children under the age of 5 are expected to receive in New York City. So this is the problem. The public health approach, we start with identifying and monitoring the problem. So we identify that we have a potential for outbreak. Now, why is this important? When vaccine rates fall, diseases surge. We know that. We have seen that happen over and over again. I will start with a global perspective, and then I will come back to New York to let you see what we have seen before. This is polio. We had as high as 4,000 cases of polio per year in the 1980s. It dropped to the lowest levels, and in 2021, as almost undetectable before 2021, and with COVID, we started seeing an upsurge in cases again in Pakistan, Nigeria, Afghanistan, Malawi. And now for polio, the threat of outbreaks, there are certain countries now that are now on the list that have not been on that list for years. So the world was able to eradicate smallpox, and we were very close to doing the same for polio. Now, all of that gain has been reversed. The number of paralytic polio cases reduced from over 350,000 per year in the 1980s to just 42 cases in the year 2015. In 2021, polio cases increased to 649. Now, again, remember that in public health, we are focused on prevention. And now, what we know is that diseases prevalent elsewhere are just a plane ride away. It is a recipe for an outbreak. It is just a matter of time. It's going to find its way here. Recent outbreaks in New York have shown us that that is a possibility. So in 2018-2019, there was a measles outbreak in Brooklyn, over 600 cases. In 2014 to 2016, there was whooping cough pertussis outbreak in Brooklyn, over 200 cases. In 2016, there was a chickenpox outbreak in Brooklyn, over 200 cases. So we are worried that we are likely to have another outbreak. Now, this is the trend in the largest measles outbreak in the United States since 1992, over 600 cases. And this is what we saw in that pattern. Remember, in public health, we use data to monitor the problem and to identify where we need to intervene. So here in this chart, you will see how the diseases increased over time from October 6, 2018 to 2019. This is measles. Now, the dark orange, brownish color, that's Brooklyn, Williamsburg. So you will see that we have the most cases in this part of Brooklyn. And then in Brooklyn, Borough Park was next. And then Brooklyn, Sunset Park, Brooklyn in other places, then some parts of Staten Island. These are the main places where we saw cases occur. Now, you may have heard, we have found a case of polio in New York City. There is polio in the wastewater. So we started to brainstorm. How can we help prevent an outbreak? Again, where coverage is low, outbreaks likely will happen. So this is the map of polio vaccination coverage with 3 doses in New York City by zip code. Now, this area of Brooklyn has the lowest vaccination coverage, and this area of Staten Island and this area of Queens, which is the Far Rockaway. So highest coverage, lowest coverage. I'll talk about the lowest coverage. Lowest coverage, Williamsburg, 11206, Battery Park City, Bedford-Stuyvesant, Clinton Hill, Fort Greene, East Williamsburg, with rates lower than 70%, and the lowest rate by far is in 11206 of 56.3%. So there is concern that it is possible that outbreaks will happen here because vaccination coverage is low. Now, let us layer that on COVID. With COVID, you see a similar cluster of low vaccination coverage with COVID as well. So during COVID, we also noticed that there were pockets of the city where vaccination rate was still less than 70%. And this pocket, again, the Williamsburg area, this very, very lighter color, this is even less than 50% coverage, parts of Staten Island again, and the Rockaway again. Now, I have listed that out for you so that you will see the neighborhoods with the lowest COVID-19 vaccination. Borough Park, 11219, Edgemere, Far Rockaway, Midwood, East Williamsburg, Tottenville, Bed-Stuy, Clinton Hill, Flatlands, Williamsburg South, Crown Heights, and Bed-Stuy, Ocean Hill, Brownsville. These are the areas that have the lowest vaccination coverage, but Bed-Stuy, Ocean Hill, Brownsville has at least the 70%, and Crown Heights has at least the 70%, Williamsburg South 70%. So the others are still below the 70% threshold that we are trying to get to for at least 1 dose. And when we look at completed vaccination series, it's even lower. So these are reasons for concern. Now, when we look at children who are the most vulnerable for vaccine preventable diseases, we are even more concerned that in these neighborhoods, we have rates as low as 17% for child vaccination for COVID. East Williamsburg as low as 17% of children youth and children under the age of 18 are vaccinated in New York City. And when you look at completed vaccination series, it's 13%. So these are the reasons for concern. Now, this is 11219. This is Borough Park that has the lowest vaccination coverage in New York City. And you will see that it is a sharp contrast with the rest of the neighborhood. So this is the zip code. You will see rates as high as 100% here, vaccination coverage, 98%, 77, 96, 83, 100, 70, and then we begin to see rates like 22%, 25%, 20% in this cluster, neighborhood cluster. And we also mapped access to vaccination at their vaccination sites. And yes, their vaccination, this is Premium Health Center, Pediatrics, this is Ezra Medical Center. So there are vaccination options there, but uptake has been low. So the public health diagnostic process, we identify who is or isn't likely to get the vaccine. We identify why. Are they likely or not likely to get the vaccine? And then we identify how do we respond. So I have shown you a little about who isn't likely to get vaccinated. And now let's go to why. So I have shown you the demographics, the spatial differences in vaccination coverage in New York City, and the previous outbreaks that have occurred in clusters of neighborhoods in New York City. But there's a problem. There are limitations in demographic targeting in vaccine confidence. Demographic targeting only helps us to identify who. It doesn't help us answer the why and how. Vaccine confidence interventions have focused on demographic groups, we know that now with all the data, rural residents, Black individuals, Republicans, lower income individuals, essential workers tend to express lower likelihood of vaccination uptake. But people are more complicated than their gender, their race, their political party, or where they live. That is not a full description. Targeting populations solely based on demographics misses the underlying barriers shaping a person's intention, especially barriers that are malleable and multidimensional. So it is not enough for us to say, this group didn't get vaccinated. We have to ask why, and we ask how. So at the Department of Health, we apply psychosocial approaches. The psychobehavioral approach helps to further segment people into groups based on their barriers and beliefs, those things that influence why they express reluctance to get vaccinated. Now, there are 5 groups. The enthusiasts, these are people who are super excited to get vaccinated. They don't need a lot of convincing. The watchful, these are people who say, I want to watch and wait. I want to see others go before. They are the cost anxious, the people who say, I don't have the time, it's too far away, it's not convenient. There is some cost to this vaccine that is limiting their ability to get vaccinated. And then there are system distrusters. These are people for whom the system has repeatedly failed to meet their needs. They have been discriminated against. They don't trust the government. They don't trust the system. They don't believe that we're saying the truth. They think we're exaggerating, etc. So system distrusters are also prevalent. And then there are COVID skeptics, people who say, we don't even believe in COVID. We don't believe that this is a thing. Now, what you will notice is that in all of these categories, these 5 psychobehavioral segments, we have people of different gender, we have people of different geography, we have people of different races, we have people of different parties, we have people at different income levels. So it is not enough to say, oh, gender, geography, race, party. We have to also think of why people are not confident in this vaccine. So what we have seen over time in all of our outreach and education and community engagement approaches, we have found that the watchful, the cost anxious, and the distant distrusters are the most persuadable. They are the people that we can, if it is your watchful, we can show you social proof that this vaccine is safe. In New York City right now, 7 million people have received at least 1 dose of vaccine. So we can show that the vaccines are safe. So for the watchful, we can convince them. The cost anxious, if we make vaccines easier, we take vaccines to their home, we help people schedule their appointments, we bring vaccines in mobile vans, etc. Then we overcome the barriers. Now with system distrusters is helping to show that we are trustworthy as a system. And we enlist the support of trusted messengers and of other community members to help them see that this is working and everyone is using it, and help to build trust over time. So these 3 categories of vaccine persona we have found to be the most persuadable. We have not needed to persuade the enthusiasts so that we knock them out. But we also have the skeptics, who are very hard to convince because their family-held beliefs, including conspiracies, that are very difficult to shake. Now, this group make up at least 17% of the population. The three segments, the persuadable, are easier to convince. Now, we also identify why. Why are people, these 5 vaccine personas? What are the barriers that each persona has? The enthusiast, the main concern is appointment availability. Once we make appointments available, boom, they're there. They're, scheduling appointments way in advance. The watchful community norms, vaccine safety are what they're most concerned about. Once we address those things, then they're easy to convince. Cost anxious, financial cost, time, vaccine safety. The system distrusters, trust, access, and inequity, and then vaccine safety. Now you will see a common thread here: vaccine safety, vaccine safety, vaccine safety. And then COVID skeptics, they have deeply held beliefs around COVID-19 that are hard to shake, and also concerns about vaccine safety. So you'll see a common thread here. Every group, every vaccine persona is concerned about the safety of the vaccine, with the exception of the enthusiast. So vaccine safety must be addressed, and people must be convinced that the vaccines are safe. Now, what are the best ways to demonstrate that vaccines are safe? We will target all of the different areas, barriers that have been identified. So increasing vaccine confidence needs tailored approaches. There are differences and then there are commonalities. Increasing vaccine uptake depends on how well we address the key perceptual and structural barriers that affect the intention to get vaccinated. We must prioritize these barriers to vaccination. Without doing so, we're in the danger of not reaching the vaccination coverage levels to stop disease transmission, or to limit the public health impact, or to stop outbreaks. So we are in this conundrum where we need vaccine combination coverage to be high to prevent outbreaks, but we have not succeeded in reaching certain populations. So in 2021, the Department of Health, how do we respond to this challenge? We launched the Public Health Core. Now, this is a partnership with community-based organizations to help reduce the gaps in COVID-19 testing and vaccination rates by race, ethnicity, place of residence, and age, and to help expand access to other services, care, resources, and investments in the communities most impacted by COVID. So this involved contracting with several community-based organizations to provide community health education, health navigation and needs assessment, service provision, and expanded access to care. We partnered with several community health centers to provide additional support to help get vaccines more easily to people. And then we also provided training opportunities for the community-based organization and constant dialogue to learn from them and to provide the data to them so that they are better informed to tailor their work. And this is what we did. So we identified areas of the city where vaccine coverage was low. We contracted with over 80 partners, and these partners covered 74 zip codes, and you see them all in different colors because these are different sources of funding. And through this partnership, over 100,000 people are engaged each week, and then vaccine referrals, about 12,000 each week, providing information in the local language, one-on-one, with space for people to have questions, help to move the dial, help move the needle in vaccination uptake. These partners were able to provide support in different languages to help answer the questions and overcome the barriers in these neighborhoods. And this is what we saw. Now, when we started this process in 2021, in May 2021, when the contract started, the orange line there is the NYCHA resident. These are the public housing residents. The green line there is the tree residents, that the Task Force for Racial Inclusion and Equity neighborhoods. There's 74 zip codes that were supported, and the blue was the rest of the city. When they started, this was how far apart they were. Over time, with all of the city mandates, policy changes, etc., and all of the community engagements, what we saw was that in NYCHA, we did not only catch up in vaccination coverage. Now NYCHA has a vaccination coverage as at today of 94%, met up with the rest of the city and overtook the rest of the city in terms of vaccination coverage. In 3 neighborhoods also, we closed the gap to less than 5%. So This was a tested model. Remember the public health approach, we monitor the problem, we find out what the problem is, then we find out risk factors and protective factors, and then we start testing our interventions that work. So this was a sample of the intervention using community-based trusted voices to get messaging in local languages to the community, and it worked. So we started also looking at how we can expand this work to other areas, to other vaccine preventable diseases. Now, we have boosters now, and we continue to encourage communities to participate. These are some of the numbers that we have for New York City. These are total COVID numbers from when vaccination started from January 17 to 2021. People want to know, do these vaccines work? Are they safe? Now, these are some numbers that can help us in that conversation. Those who are unvaccinated, this is the cases that we have seen, vaccinated, not boosted, lower incidence, and then vaccinated and boosted, even lower cases. Now, COVID vaccination does not mean you will never get COVID, as you can see here. But look at the difference in hospitalization and look at the difference in death. So vaccination doesn't bring the incidence to zero, it brings it down. Remarkably, it reduces hospitalization and reduces death in COVID. There are some vaccines that you get vaccinated and you're immune. COVID is not one of those vaccinations. So we want people to see the numbers. It reduces the likelihood of you getting hospitalized and dying from COVID. So vaccinated New Yorkers have had much lower rates of cases, hospitalizations, and death. And these numbers also reveal that the vaccines are safe. So we started reaching out to our community-based organizations that work in Jewish community, that serve Jewish community, and say, can we use the same approach here? And we put out a solicitation for community-based organizations that are willing to do community education and provide support to the neighborhood to help people understand how these vaccines work, that they are safe, etc. And we have all of these partners that are now contracted, working with the Department of Health, the Borough Park Jewish Community Council, Ezra Medical Center, the Young Men, Young Women's Hebrew Association, the JCC, JCI, Coney Island, JCC, JCI, GCI, Far Rockaway, JOWMA, the Staten Island Performing Provider System, Staten Island Not-for-Profit, ODA, Primary Healthcare in Staten Island, Premium Healthcare. Now, these organizations were engaged to deploy localized, customized intervention. Design the message in a way that will resonate, say it in the way that's not offensive, help to answer questions, respond to other needs that the community may have, helping local decision makers develop customized messaging to the specific persona of the communities that they serve to spur vaccination uptake. Now we've had 3 months of that work. So here we have vaccine equity for the 9 Orthodox Jewish communities that we have been supporting through this partnership. And this is where numbers were in June. For June, as of June 1, our hope was to get the vaccination coverage to 45% for these neighborhoods. You will see that citywide vaccination coverage among white New Yorkers was 63%, but in some communities it was much lower. So after this period, as at August 31st, this is where we were. We saw increase in vaccination for 4 out of 9 zip codes. There were some zip codes where nothing changed at all. And in these zip codes where things changed, we saw vaccination go up by 1%. So we are encouraged that in some areas, there's some responsiveness. In many other areas, nothing changed at all. So in Staten Island, on the contrast, among white residents in Staten Island, there are 5 priority zip codes that we funded partners to support. And in all 5, the vaccination goal was to get to 45%, and they all have exceeded that. And now we have rates in the 50s and 60s for these 5 zip codes in Staten Island. So we saw a lot of growth in Staten Island, but not as much growth in Brooklyn. So what we have found is the greatest movement was among the watchful and the cost anxious. System distrusters showed slower movement, and the COVID skeptics were largely unchanged, remaining unconvinced about getting the vaccine. With the imminent threat of new disease outbreaks, we must not only prioritize the persuadable, we must focus on dismantling the barriers that stand in their way, and we must also convince at least some portion of the COVID skeptics. This is not going to be easy, but it is not impossible if we work in a targeted way. So we are hoping to bridge the public health world and the medical world, working together to build greater vaccine confidence. The chances are we all know people in our communities who fit this persona. It's important that everyone, not just public health professionals or policymakers, work together to build greater vaccine acceptance in the United States. Again, the goal is to prevent outbreaks. So how can healthcare professionals help? We want to encourage you all to ask every patient about their vaccination status. COVID, polio, flu. How do you feel about these vaccines? This is a good way to start. And then identify what barriers, see what kind of vaccine persona they may have, and then identify how you can help them address those barriers based on their vaccine persona. I like to use the health belief model to address the perceived threat of disease and to provide a cue to action. And then also the North technique is helpful in having conversation, and I'll walk you through them. So this is the health belief model. Individuals have perceptions. They have a perceived susceptibility to disease, and they have a perceived severity of disease. So if people think it's not serious, they're not going to budge, especially when it is a preventative approach. People will go lay themselves down to all kinds of invasions for treatment when they're sick, but selling prevention is hard. So it has to do with both the perceived severity and perceived susceptibility to disease. So these are two areas where providers can help. Now, this also varies by demographic variable, age, sex, race, ethnicity, etc., and then their psychosocial profile. Now, these two combined leads to the perceived threat of disease. Okay, it's not a big deal. COVID is not a big deal. Polio is not a big deal. Measles is not a big deal. And I'm okay. I'm immune. I had COVID already, so I'm good. So the perceived susceptibility is a big part of this. Now, cues to action matter. What are people exposed to? What kind of information, the media that they're exposed to? What advice are they getting from people around them? What are the physicians or their dentists or the people around them are saying? Have they experienced illness in family member or friend? We found that those who have physically experienced COVID were more likely to be interested in preventing it, especially for the sake of their loved one. What are they reading in the papers and magazine articles? So all of these are cues to action that reinforces or addresses the perceived threat of the disease. Now, overall, for us to get to people to the likelihood of taking recommended preventative action, they have to perceive that the benefits outweighs the barriers. And this is where we come in as providers, helping them see the benefits, helping them address. Human beings are not very good at estimating their own risk. People will get into a car, say, I'm good, I don't need a seatbelt. People will do all kinds of risky things because our risk perception is limited. We are not always able to objectively assess how at risk we are. And this is where we come in as providers. These are ways that we can help address all of these different areas. Help people see that, oh, we have had outbreaks in this population. Everyone who's not vaccinated is at risk. Help to personalize risk based on what you have observed. Perceived severity, specify the consequences of the risk and the condition. We're not only worried about the morbidity and mortality from COVID, but also about long COVID. These are all preventable things. Perceived benefit, help people to see how one shot, taking it, you may have some discomfort 1 or 2 days, but it makes a difference. The number of people we see hospitalized, the number of people we see die is reduced among those who are vaccinated. Perceived barriers, what can we help you overcome? Identify and reduce barriers through reassurance, through incentives, through assistance. Cues to action, provide the how-to information. Oh, this is very easy. We have premium health, we have centers around that can provide this vaccination. We have JOWMA that has the hotline. If you need to ask questions, they can help respond to questions. And there's self-efficacy. Do they feel empowered to be able to do this? Now, I also like to share this with you. We use this approach with our community-based organization, the North Technique. Normalize, use open-ended questions, provide resources, work together, and be honest. Normalize means if, for instance, you see a patient and he says, I am not having any of those vaccines. We have heard that these vaccines cause all kinds of side effects. We have to start by assuring the clients that it is normal to have these questions, that I can understand why you're concerned based on the things you have heard. We have to validate people's fears, and we have to assure our clients that it is normal to have these questions and doubts, and then ask them open-ended questions. What have been your own experiences? The experience of members of your family, anyone that you know that has been vaccinated, share culturally and linguistically appropriate resources. These are the community-based organizations that have worked with hundreds of people to get vaccinated in this community. People hear about all the horror stories, but there are millions of people that have been vaccinated. They can share their own stories and their experiences. Then work together. You don't have to convince the client to get the vaccine. We don't want them to feel pressured or threatened or feel like if they don't get the vaccine, there's something bad, they're not going to get some services. But instead, we want to work with the client to get accurate information. These are sources that you can go for accurate information. They are developed by trusted people. They're members from our community. They know us. They know the truth. These are sources that you can go for information. Then share honestly. We have found that the most powerful way to help people understand the vaccine is by sharing your own experience. Like, I have been vaccinated. We encourage our community partners to show people their own vaccination card. Like, look, I got the vaccines. I've got 3 doses and I'm here. Everyone in Department of Health, we're mandated to be vaccinated. We're all here. It's a department of 7,000 people. We see people every day. No one has fallen over since being vaccinated. We're all doing good. So share personal experiences and reasons why you chose to get vaccinated. We did a recent survey and people say we want to see pediatricians who were vaccinated. We want to see pediatricians with children and their children vaccinated. Then we will know that this is safe. So sharing our experiences matter. Now, Governor Hochul has declared a state of emergency for polio. And this is what that means. That means that we are now going to be working to improve vaccination for polio. So we are again in your faces trying to avert another outbreak. So now we are immediately expanding the network of vaccine administrators, adding EMS workers, midwives, pharmacists, making vaccinations more readily available for those who need it. The New York State Department of Health is also continuing to assess the spread and to prevent disease through monitoring and vaccination. So monitoring is where we thrive in departments of health, tracking the data, looking at it, interpreting it, and then working with local and national authorities, healthcare providers, and community partners to see how we can help prevent disease. So we have had 1 case of paralytic polio, which is 1 case too many. Paralytic polio is no fun. And if it can be prevented, we are particularly distressed by that fact that this is happening in New York City and that in New York State, where it could have been prevented. Now we have seen more poliovirus detected in wastewater samples from several counties: Rockland County, Orange County, Sullivan County, New York City, and now Nassau County. So this is what has led to this state of disaster emergency, seeing how can we prevent more paralytic polio occurrences in New York City. So I will stop there. I don't know if there are folks in the room that have questions, but my attempt has been to show you the public health perspective, how we arrive at decisions, how we identify who needs support, how we identify why they are not confident in this vaccine, and how we have been responding. And if there are other areas or questions that you would like me to respond, please go ahead and let's dive right in.
Thank you so much for your talk tonight. I found that very insightful. If anyone does have any questions, feel free to put them in the Q&A box, but I will ask one. I know you mentioned responding to the middle three vaccine personas mainly, but how do you suggest responding to COVID skeptics, like the ones who are spreading conspiracy theories? Do we bother targeting that group if their beliefs are so deeply rooted?
The answer is yes. We have neglected to respond to the COVID skeptics, and we are faced with the reality that we are not going to be able to stop transmission if we don't get rates higher in some neighborhoods. And in those neighborhoods, we find that there are a lot of skeptics. So right now we are at the stage of exploring how we can best respond to skeptics. What we have found to be most useful is social proof. Getting stories from those who have been vaccinated from their communities more widely disseminated. People have heard all kinds of horror stories, and those have really terrified people into like, I don't think I'm going to do this vaccine. But what we have found, for instance, in Jewish community, the uptake of monoclonal antibodies was good. People didn't have a problem accepting monoclonal antibodies, but vaccines do the exact same thing. So are there ways where we can discuss more using examples from the community, people who have been vaccinated, who are able to share their stories? I am vaccinated, my kid is vaccinated, and we're here and we're doing okay, as ways to counter the negative narrative that we have heard mostly. Polio, we are really worried about for children. And if there are examples of, family providers themselves who have been vaccinated, who have children that have been vaccinated, that can help the skeptics see that this is real and this is happening in our community and we can do something about it, maybe that can help.
All right. So thank you again for the work that you do and for your lecture tonight. It was very interesting and I learned a lot. And thank you to everyone for joining us tonight, and have a good night, everyone.
Thank you. Be safe.